The kidney is an amazing organ. And let me make sure that I don't make this go too fast. Okay. So I've got it all. I've got 3 pictures here. So you've got your big kidney, you know, it's a bean-shaped organ. We've got 2 of them in our body. And I put the amazing kidney in. Why is it so amazing? Because between both of them, they receive about 1 liter of blood each minute. So your heart pumps out, what, 4 to 6 liters. So the kidney is receiving about the kidneys are receiving about 1 liter each minute. So the reason why we say the heart and the kidney goes together is because the heart has to perfuse the blood to the kidney, to pump the blood, right? So the kidney is kind of filtrating about 1 liter of blood a minute. So if you look at the second picture, that is actual where all the work happens. That's the tiny little glomerulus. There's so many of those. There's thousands, million probably, hundreds of thousands in the kidney, and that is what actually filtrates the blood. And then it removes the waste. So the kidney actually gets rid of not only waste, but some extra water that we don't need, because the body needs water, but there is some extra water we don't need. And so it eliminates about 1 to 5 liters of urine a day. So, and then it gets rid of the waste through filtration. So it has 3 jobs besides filtration, which is the big job. But under that, you've got excretion, secretion, and reabsorption. So secretion, it secretes some of the hormones that we need, and then reabsorbs some of the fluid and electrolytes and the hormones, and then it excretes the waste and some water. You've got a renal artery that takes the blood in, and you have a renal vein that takes the blood out. And then you have the ureter, which actually filters the urine or the waste. So all of this is the picture is basically kind of an anatomy review of the kidney. But over here, this last picture, that is the glomerulus. And that is where all the magic happens as far as the filtration of the blood. Those microscopic bundle of capillaries filter the blood through there. So the reason why I say it's amazing is because it is a marvelous feat of natural engineering. It's, the way we were made, and despite medical advances and technology, there has been no one that can actually make an artificial kidney. We can go to dialysis and they can filter the blood, but they've not been able to copy or make build an artificial kidney. There, the glomerulus, right there, you've got your Bowman's capsule, and within your glomerulus, within that system, you have your juxtaglomerular apparatus and your juxtaglomerular cells. And the reason why I feel like those are important is because within that glomerular apparatus, you have what is a baroreceptor, and which I remember from baroreceptors from the heart. It's a receptor, and when there's those in the heart too, remember, for stretching. So when the baroreceptor realizes that or sees that, or feels that there's less volume, less blood, less volume, that's when it signals the kidney to release renin. So that is a secretion of renin when that happens. So that happens there in that bundle of capillaries. And you all know about the RAS system, right? Do you remember? Everybody feel good about the RAS system? When renin's released? Okay, so that's where that happens, and that's why it happens. Is if it's perceived, you know, it's a given if someone's got like hypovolemia, right? And there's not enough blood. The heart's not pumping enough blood through that glomerulus. But sometimes it can be a perceived thing. The body may perceive that it's low and release renin. So I just wanted to make sure you understood that that's where that happens, and not that, you know, it's really just a review of your anatomy. But so you've got your glomerulus, which that's where the filtration happens, takes blood from the renal artery and filters it. And then you got your proximal tubule, and that is where like 80% of your electrolytes are reabsorbed, your water, your amino acids. And then your loop of Henle, if y'all, you know, recall loop diuretics, that is the reabsorption of sodium and chloride into that the loop there and concentration of your filtrate. And then your distal tubule, and see if I can make this bigger. Okay, I don't know. Your distal tubule over here on the right there, that is actually where a lot of secretion happens as well. Secretion of potassium, ammonia, hydrogen, reabsorption of water as regulated by ADH. And then your collecting duct, which also reabsorbs water, and ADH is required for that. So that is just a overview of how intricate it is. It is, and that's why I call it amazing, because there's so many of those. There's about a million. It's, you know, you've heard different ones, but the nephron, which is the functioning unit, has about 1 million. There's about 1 million nephrons, so there's so many of these this system that the glomerulus and everything that filters blood, that you actually, the reason why it's considered kind of a kidney disease is kind of considered a silent killer, people don't know, is because you can actually have 3/4 of your kidney not working, of all the 3/4 of these million things not working before you realize that you're in kidney failure, before they pick it up. So that's why it's so important. We're going to talk more about it, but we're going to talk more about how important, you know, conserving the kidney and you know, of course, caring for yourself before you get to that point. So let's move on. So the functions of the kidney. Like I said, the overall function is filtration, but there's so much more. So much more that it does. Like I said, it releases renin, and that word is excretes sodium. And it excretes a lot of things, but renin. So that is especially key in regulation of blood pressure, right? The renin? Yeah. Elimination of metabolic toxins in water through urine. Everyone knows that BUN is your end product of your metabolism. And then creatinine is your end product of muscle, that says muscle metabolism. BUN is blood, urea, nitrogen. It regulates the pH, so it's help regulate the acid-base balance. And that's kind of where reabsorption comes in. Because the reabsorption is you're reabsorbing some of those vital electrolytes, and it's kind of the regulatory system. So think reabsorption, regulatory, homeostasis. And then regulation of the erythrocyte production. So erythropoietin is a hormone released from the kidney that stimulates the bone marrow to produce red blood cells. All right, and then the kidney also regulates mineral levels. Like I said, as far as reabsorption, you've got your reabsorption of your calcium and your phosphorus. That all happens there in the kidneys. It actually happens in the distal tubule. So that is why calcitrol is an activated form of vitamin D. And it's needed for absorption of calcium via the GI tract. And we're going to talk more about that when we talk about bone mineral density problems related to kidney failure. We'll go more in depth with that. That's just an overview of the functions of the kidney, and it maintains homeostasis overall with its filtration. So your basic process is your glomerular filtration, tubular reabsorption, tubular secretion, and excretion that all contribute to urine formation, right? So it is, like I said, it's an intricate process. That's why I call it the amazing kidney. I just want to give you a comparison here. Acute kidney injury, because that's important for you to know the difference. Acute kidney injury is sudden. And as far as chronic kidney disease, you think chronic is ongoing, it's gradual, and it happens over many years. Can acute kidney injury turn into chronic? Yes, it can. They say usually if you've got an injury and it prolongs and you're just not getting better, over 3 months it can turn into chronic. They start looking at your GFR and all that, but acute kidney injury is sudden. This is someone that's in the hospital, they're septic, they're not perfusing the kidneys, and they go into failure, right? The most common is acute tubular necrosis, and that is just, what is necrosis? That's just the sloughing off, the kind of the dying of those tubes. That is often, when you think of that, think of like damage to those tubules. You know how you can get a hemolytic blood transfusion reaction? That's going to damage those tubules. Another thing that damages the tubules, lupus. That autoimmune where it attacks the body. can damage the tubules. As far as diagnostic criteria, acute reduction in urine output, right? And then, or an elevation in your serum creatinine. And is it reversible? Yes, it's potentially reversible. And the primary cause for death is infection. Why do y'all think that's the primary cause of death? Why do you think infection is the primary cause of death? Huh? Right, right. The buildup of the waste, the urea and the uremia in the blood, the waste product, not getting filtered out, can cause your whole body just to go septic. Septicemia, sometimes just the fact that you're in the hospital. You can get the hospital acquired infections, that kind of stuff. So infection is the leading reason. And then chronic, and we're going to go more over chronic when we go to talk about chronic, but I just like this comparison. So chronic kidney disease, the most common cause is diabetic neuropathy. And then your GFR is less than 60 for greater than 3 months, and or kidney damage for greater than 3 months. So basically, kidney injury for greater than 3 months. And then is it reversible? No. Chronic is progressive and irreversible. The only thing you can do once you know you have chronic is to try to conserve, follow, be compliant, do what you're supposed to do, take your medicines. We're going to talk more about that. But it is irreversible. And then the primary reason for death in chronic is cardiovascular disease. When I worked in dialysis, most of the people did not die from dialysis. They died from cardiovascular disease or infection or something like that. Sometimes cancer. Okay, let's talk about the causes of acute renal failure. So, pre-renal. That means above the kidneys. It's a sudden and severe drop in blood pressure, like shock, or an interruption of blood flow to the kidneys from severe injury or illness. And then you've got your intrarenal, and that's direct damage to the kidneys by inflammation, toxins or drugs, infection, or reduced blood supply. So think inside the kidneys. And then postrenal is a sudden obstruction of urine flow due to enlarged prostate, bladder tumor, kidney stones, or injury. And we're going to make more notes. Let me show y'all this next slide before you write a bunch on this one. Okay. So this is right from your book. And I like it because it is nice and evident on what is pre-renal. So you've got your pre-renal above the kidneys. Anything to do with your heart and all the way down, even your renal arteries. So we had a student last semester who was talking about, I think it was her boss or someone had gotten a pulmonary, or an embolus, not a pulmonary embolus, but an embolus stuck in their renal artery. And that would have been pre-renal failure, acute failure, and they lost their kidney because of it, because they couldn't figure out what was going on. I don't guess they did the right test. But anyway, they ended up losing their kidney because of it. So pre-renal is anything above the kidney, including that renal artery. So anything that will decrease the circulating blood volume above the kidney. And then your intrarenal, think of prolonged ischemia into those inside the kidney. Think of that amazing kidney and all those intricacies. Prolonged ischemia, nephrotoxic drugs. An ATN is acute tubular necrosis. What are some things that I said before that could cause the intrarenal? We were talking about acute tubular necrosis, and I said, are y'all listening? Lupus. Yes, lupus can cause intrarenal, right? What else could you think of that would cause intrarenal damage? Drugs, like, what are some of the drugs? Immunoglycosides. Did someone say gentamicin? Vancomycin. And then what else? Hemolytic blood reaction. That can cause problems. So anything that's going to cause the necrosis of the tubular tubes. So that's intrarenal. There's several things I think listed in your book too. What else could cause intrarenal? We didn't talk about it. Yes.
What's ATM?
Acute tubular necrosis. What about dye? Contrast dye? That could cause intrarenal failure. So I always say drink water and make sure they have fluids. Flush that out. The same thing with meds. When you're on antibiotics, does your doctor tell you drink lots of water? Any antibiotic, really. I mean, there's some that are worse than the others. But you don't want them just sitting in you don't want those antibiotics just sitting in your kidneys. You want to flush everything through. So that's why it's important to drink water. All right, so postrenal, below the kidneys. So from the ureters down to the bladder. Enlarged prostate, tumor, injury. Everybody knows what calculi is, right? Kidney stones. Any kind of outflow problem. They can't get their urine out. It's going to back up. It's going to cause problems within the kidneys. Casts. Casts are when your tubules, your ATN, acute tubular necrosis, your tubules are basically kind of sloughing off, and you will get cast in your urine. They're microscopic, can't see them with your eye. They have to see them, with a microscope. But if you ever hear someone's got cast in their urine, that's not good. That is a sign of failure, sign of problems. Actually, all right. So what are you going to see? How are we going to know our patient is going into renal failure, acute renal failure? We're going to see oliguria, a reduction in urine output. And because of that, you may also see azotemia, which is an accumulation of urea, which is nitrogen waste. The kidney's not able to get rid of that waste and reabsorb it, send it out. Then it's going to leak into the blood. So you may see some azotemia. Increased BUN, increased creatinine. There is a chart in your book. It's called, I think it's the rifle chart, and that's the beginning of it here. It's the first thing is risk. You're at risk if your increased creatinine 1.5 or your urine output is less than 0.5 milliliters per kilogram per hour for 6 hours. So that means you're at risk. That means, let's see what's going on with this patient. So that's why you have to make sure you're monitoring your patient's urine output. That's not something just for the PCTs to do. You have to make sure your patient is using the bathroom.
Is that a 6 hours?
6 hours, yes. So for 6 hours. So injury is greater than 2 or urine output less than 0.5 kilograms per hour for 12 hours. An example would be sustained hypotension for a period of time because the heart's not perfusing that blood. And then failure, increased creatinine to 3 or urine output less than 0.3 kilograms per hour for 24 hours. This rifle table here, 47.3, page 1103, that's the 9th edition. And then the 10th edition is page 1071, table 46.3. That's just your rifle. Do you need to know this in detail? That's what your next question is, right? That's what you're thinking. We're going to talk more about GFR, but if your GFR is decreased by 75%, that's a lot. Or if you're not urinating for 12 hours, that is definitely a case of failure. And we're going to talk too more about this waste accumulation because as it gets into chronic, they call it something else, uremia. I don't know why, but we'll talk more about that. But with any kind of waste buildup, you're going to see these neurologic changes because your kidneys it's not reabsorbing it and getting rid of it. Does that make sense? Okay. So as far as your at UA, your analysis, you may see CAS, like I said. Red blood cells, white blood cells, protein in the urine. And your specific gravity is going to go up to 1.010. What is specific gravity? It's the kidney's ability to concentrate the urine, right? Does everybody know normal specific gravity? 1.0033 to 1.030. So if it's really high, 1.030, that would mean just that there's dehydration, right? If it's low, the urine's dilute. If it's high, there's dehydration. Well, as far as this number, the specific gravity here, this indicates just you've got more problem with the kidney being able to concentrate the urine. All right, so as far as we were talking about oliguria, but let's talk about the oliguric phase now. The oliguric phase is a reduction in urine to less than 400 milliliters a day. So there's different phases that the patient may go through when they're in acute kidney failure. And one of these phases, the first phase, is oliguric. It's a reduction in urine to less than 400 milliliters a day. So that other one I said that So this usually occurs after 1 to 7 days of injury. And the duration is an average of 10 to 14 days or months. Can be months. If they are in this phase for longer, they have a poor prognosis for recovery, because if they're not putting out urine, there's damage that occurs, and obviously there's so much damage that that's not regaining its ability to filter and to reabsorb, to do all the things it does, secrete, excrete. During this phase, we're back to this waste. The kidneys cannot synthesize ammonia needed for the hydrogen excretion. So that's when you're getting that urea. That's why I made it yellow, so you can remember it. You're going to see clinical manifestation of metabolic acidosis, that buildup of the waste, the urea. They can't synthesize the ammonia needed for the hydrogen excretion. If they were in severe acidosis, you would see Kussmaul's respirations. Does everybody know what those are? Right. That is the severe acidosis. When you see the Kussmaul's, they're in severe acidosis. Sodium balance. So damaged tubules cannot conserve the sodium. You've got to have sodium. You've got to have the balance there, right? So they're not reabsorbing it correctly. So you may see some below normal levels of serum sodium. And then potassium excess. Again, if they're not able to reabsorb the electrolytes, then you're going to see some potassium excess. The kidney's normal ability to excrete potassium is impaired. So what are you going to see? A peak T wave, widening QRS. Because potassium excess can kill someone, right? The dysrhythmia. So this is a major thing. You want to make sure that they're on a monitor if you suspect that they're in failure. How else would... All right, so did everybody get that? Okay. Now we're going to talk about the diuretic phase. So we talked about the oliguric phase. That's the first phase when they're not putting out enough urine and you're seeing all this acidosis, buildup of waste. The diuretic phase. So when the doctor suspects that someone's in failure, or they see that they're in failure and they have these clinical manifestations on this other page, they can do a few things. They may give them a fluid challenge to try to get the tubules, to get those casts out of there, because the cast can actually cause problems too. And they may do a fluid challenge. They may even give some Lasix or furosemide to try to challenge them. Once the kidneys are not working anymore, they're not working, then they're not going to keep giving them Lasix, right? Because it ain't going to help. So you're not going to give somebody that's in dialysis get on a machine because their kidneys don't work, you're not going to give them Lasix, right? But they might in the beginning challenge them with Lasix. Does that make sense? Because their kidneys are failing, they're not falling completely. They're failing. So then you may see a diuretic phase. And this is the inability of the kidneys to concentrate urine, but they can excrete waste. So they're not concentrating the urine, so you're still going to see some electrolyte imbalances, right? But they're going to be putting out 1 to 3 liters a day because their ability, that collecting duct, the distal tubule and all, the collecting duct is working, but the regulation and the reabsorption is not, so it's not able to concentrate the urine. So they're just peeing a lot, 1 to 3 liters daily. So with this, you're going to monitor for hyponatremia, hypokalemia, dehydration, BUN, creatinine levels will sometimes, a lot of times they'll begin to normalize during this phase. Because again, they're getting rid of all this fluid and stuff, but they're just not concentrating the urine. And this can last up to 1 to 3 weeks. So this is like, the doctors are thinking, okay, something's working, but it's just not, they're still not healed, basically. This is a diuretic phase, and it can last up to 1 to 3 weeks. So the kidney is still injured in this process. This is still acute kidney injury. And then the recovery phase. Now they are getting better. So your GFR is going up, allowing the BUN and creatinine to plateau and then go back down to normal. It can be up to 1 to 2 week process, but it can take up to 12 months to stabilize. So these people will be going back and forth to their doctor. They'll be getting blood work to make sure that everything's looking good, that they are stabilizing. And as far as the outcome for these patients, as with a lot of things, it depends on their overall health. How healthy or unhealthy they were when this happened to them. Yes?
What does that say, 1 to 2?
1 to 2 week process. But it can take up to 12 months. They're not going to stay in the hospital for 12 months. Like I said, they'll be going back and forth to the doctor, making sure that their kidneys are stabilizing. So what kind of tests are we going to run on these people? Well, there's a bunch of tests in your book. But you want to make sure, as far as diagnostics, that you get a thorough history, as always, right? You got to find out, do they have a history? Have their kidneys failed before? Do they have a history of UTIs? Do they have a history of diabetes and heart problems? Because that's all going to make a difference, right? In knowing about this patient. Have they been on gentamicin or vancomycin lately? All this, that's why history is so important. And then a serum creatinine, of course, a UA, kidney ultrasound, renal scan, a CT probably without contrast. Because contrast can cause contrast-induced nephropathy. Contrast-induced nephropathy, CIN, can occur if they use contrast. So the first choice would be your ultrasound, right? Because it's least invasive. Basically, just taking a picture, they can see the structure of the kidneys, they can see if there's cysts there, if they're swollen. And renal biopsy, that's done so they can actually check to see if there's sclerosing, if there's a process going on there, chronic, or that's usually when they do the renal biopsy. Treatment, what are we going to do? Our goal is to prevent complications, right? Eliminate the cause. If they're in pre-renal failure, we want to eliminate the cause. We want to give them fluid if they don't have enough fluid in their pipes. Manage the signs and symptoms. And like I said initially, they may give some diuretics to flush those tubules and decrease the potassium. Try to see if they will pee. If that happens and they don't pee, then they know. So you're going to closely monitor I's and O's. Do y'all remember talking about insensible losses? Does everybody know how to figure insensible losses? So you take, the general rule is, a lot of times you'll have to do this if they're on restriction, right? So if they're in failure, they may be on a fluid restriction. And you have to closely monitor them. And this is especially true in the oliguric phase, right? Because they're not putting out enough urine. It's less than 400 milliliters, right? So the general rule is to add all their losses for 24 hours. And insensible is what? Tears, sweat, even respiration secretions. So any of that, blood. Well, blood is a regular loss, not an insensible loss. But you take your all your losses and you add 600 for your insensible losses. So I know this. You need to know this. You will. Treatment is to treat hyperkalemia. Because like I said, it will kill you. The dysrhythmia, the aggravation to the heart. So treatment for hyperkalemia is insulin and sodium bicarb, which is a temporary fix, but it will fix it temporarily. Calcium gluconate to help calm down the heart or decrease the risk for dysrhythmias. So a lot of times they'll give the insulin with the calcium gluconate. But to actually remove the potassium, you've got to use Kexalate or sodium polycystyrene. This is something you can give by mouth, or you can even give it in an enema. If say they have an ileus and their GI is not working, you could give it in an enema. And if you think about it, you're basically, what happens is the enema goes in, and using your intestines as a filtration. It pulls the potassium into the intestines, and it is excreted that way. It kind of binds to the potassium. And then dialysis. Dialysis will actually remove it. Why would they give this other stuff and not just go do dialysis? Well, they're going to always start with the least invasive first, right? They're going to start with the easier, less expensive thing, because dialysis is really expensive. So they're going to start with the less first. Okay, collaborative care. Do y'all need a break? We got 6 more slides on this one. Y'all want to take a break after we finish this? Okay. So as far as collaborative care, dialysis, peritoneal, PD is peritoneal dialysis, hemodialysis, and then the other 2 are just a still dialysis. And the CRRT is sometimes a dialysis they use in ICU, and it's just a slower process that if someone that's hemodynamically unstable, like they're shock or septic or something, they may use a slower form of dialysis. It's continuous renal therapy. So volume overload with compromise, elevated potassium that they just, kind of greater than 7.5, or they just can't get it down. Metabolic acidosis. A significant change in mentation. So they were talking to you this morning, and they just are not anymore. They are talking about when they were 2 years old. And they don't remember when they were 2 years old. A BUN greater than 120, or they may even do dialysis if their failure has caused pericarditis or pericardial effusion or cardiac tamponade. And all that is, those things are caused sometimes from the buildup of the urea, the waste, can actually cause those problems, pericarditis, pericardial effusion, cardiac tamponade. All those would be caused for dialysis. This often, nursing management, you want to closely monitor I&O because it's vital for daily replacement of volume. Assess urine color, labs, general appearance. Of course, you're going to assess for lung sounds. What is signs of fluid overload? JVD. S3, sometimes you'll hear an S3 if they're in overload. A rub, that would be kind of scary. That could be an effusion. So you won't, they may even need an ECG. So this is just some things that, as far as nursing management, the doctor's not going to think of everything. You're going to have to realize, okay, doc, can we get an ECG here? Sometimes you have to ask for these things. Evaluate mental status. You're going to use labs, BUN, creatinine. If they have to go on dialysis, we've got to monitor and observe the site they use. A lot of times for acute dialysis, they're not going to go make them a graft, because we'll talk about that when we talk about dialysis when they have chronic kidney disease or end stage. Most of the time, they're just going to have a CVAD that they're going to use for dialysis. So a central line. If you ever see one of those, unless you have an order, a lot of times they'll be wrapped with gauze, but if you don't have an order, you're not supposed to use their dialysis catheter. You have to have a special order. I think Baycare does have this, they may have a new policy where they have a, like a pigtail on the dialysis catheter. You can use it, but you may still need an order. I'm not sure on that policy, but sometimes they'll have a little pigtail that'll be hanging out that you can use. But always just ask the nurse you got a report from, call the doctor if you have to. Make sure you can use that thing, because that's their lifeline. They say it, that's their lifeline. But you got to observe the site. Just like back to test 1, you got to know the signs and symptoms of infection. Any problems with the CVAD. Those are things you got to know. They're going to need skin and mouth care. And then, of course, aseptic technique, because infection is the leading cause of death in AKI. So, some nursing diagnoses. Excess fluid volume related to kidney failure and fluid retention. Risk for infection related to invasive lines. Uremic toxins, altered immune response to kidney failure. Anxiety, of course, related to disease process, therapeutic interventions, uncertainty of prognosis. Okay, as far as implementation, we got to recognize the risk factors. Careful monitoring, prompt replacement of fluids. Manage the fluid and electrolyte balance, especially during your oliguric and diuretic phases. Follow-up appointments. Make sure they know the importance. And then long-term is appropriate referrals for counseling, for follow-up regarding what they need, psychosocial, even financial hardship, especially if they end up having some chronic problems and they may go, need dialysis. That's very expensive, and this doctor bill will be very expensive, so they're going to need possibly some referrals. As far as evaluation, how do we know what we've done, what we're doing for the patient is working? So they regain and maintain normal fluid and electrolyte balance, right? That is our hope. That is what we want. They comply with treatment regimen. Part of the art in nursing is talking them into doing things they need. You've seen that nurse. She's tired. She's been a nurse for a long time. You want them to experience no untoward complications. That would be no hospital-acquired infections. Definitely. You don't want them to leave the hospital or not be, or have to have several CVADs because we're not, monitoring it close enough. So any untoward complications. You want them to have complete recovery. That's the goal. That's the evaluation. That means we did a good job. We were doing what we needed to do to help this patient recover. And that is all. That is all of acute